So Elena is highly expert. She's got a marvelous multidisciplinary team working with her in her research of important international importance. Elena's work, she's a leading light in the Movement Disorder Society and will be speaking at the Movement Disorder Society, for instance, next week, when we meet in Berlin in 10 days' time. Anyway, it's been lovely to get to know her, and she's been over talking to the team. We've been discussing research collaborations between Dublin and Grenoble, and that's the great thing about the internationalization, and we're part of that. That's important to realize. We're part of that dynamic, she's a warm, effusive individual and full of common sense. Michael, you don't do that, you know. Anyway, so it is my pleasure to introduce Elena, and she has to leave quite promptly at 10. So if you have any questions, you have to get them in, because she has to leave for the plane from Dublin to Lyon this morning. Thank you very much, Elena. Thank you for coming.
So this is a topic which I like quite much, because I think that for a physician to see the wonderful thing that we can do when botulinum toxin doesn't work is quite rewarding. And you will see some of the videos that I hope that you don't videotape for yourself, because I get the consent from my patient just for few things. So just watch. So let's start. So how we do this kind of strange surgery? Well, over the years, the engineers, they have worked quite a lot. The surgeons have MRI facility, and they have some programs. They help them to reach the target. So it's not so difficult, if you are a good neurosurgeon, to reach the target inside the brain using the MRI. So it's a relatively easy technique for neurosurgeons. So you can see in the OR, they have this kind of frame and to fix the head. Otherwise, you can scramble the brain. You can understand that. And the neurophysiology, they record the activity of the brain, because when we reach some targets in the brain, they have a specific signature. I will show you a video so you can hear the neurons inside the brain that they fire with a specific frequency, and we can recognize where we are in this way. So, for example, let's see this video. So you can see there is a picture of the brain here. We have to go inside this deep structure inside the brain, and you will see the electrode going down very soon. They have a program to reconstruct the possibility to go inside, so they just calculate the millimeters, and there's some robots that they will introduce the electrode. And you see the electrode going down. You can see the neurons. This is the thalamus. So there's some type of activity different from this structure that we will reach, is the subthalamic nucleus. There is a silence. There's no neurons there. And then it goes down. You can see the electrode. Then we are here, slowly. There's no sound there. Can you increase the volume? You can see this kind of activity is, and another one. You can see the noise. There are two different populations of neurons. Of course, you have to be a neurophysiologist. You get used to that. And in this way, the neurosurgeon knows that we are in the right target. And he will leave the final electrode that is going down now, because these are microelectrodes. There will be the big electrode, the Medtronic one, which will take the place of the small electrode inside. And here he's coming. And he will be put into the structure of interest. So this is the way that usually the surgery is being Done. Okay, we can move on. So we have the first patient operated with deep brain stimulation was in 1997. So almost 20 years, right? So in these 20 years, we have accumulated experience. So we know quite a lot. So, but you say, well, who are the patients who can benefit from this treatment? So we try to write some suggestion. So basically, there are the patients that they cannot be improved with medication or botulinum toxin, and they're still very disabled. It's not because the neurologists tell you, oh, yeah, I don't like you, that it's you. If you feel that the disability is really severe, you can't cope, you can't work, it disturbs you, so you can be a candidate. It's really the disability, the main criterion of selection for the brain stimulation by now. Okay. So what do you need for being considered for this surgery? Of course, a brain MRI, a cervical MRI as well, because sometimes the pain that you can have from the cervical dystonia can be due to arthritis. So we want to be sure that the pain will go away if it's due to dystonia. If it's due to arthritis, operating the brain doesn't work, right? So we want to be sure that the expectations are met. And then we do videos, you know very well, for having an idea, and you will see the videos before and after surgery, because you don't forget, you know, how you were before. And then we do some neuropsychological testing to be sure that the brain is functioning, all function of the brain is okay, because in any case it's a brain surgery, so there can be some contraindication or some side effects. And then, of course, we discuss with you and the surgeon, because also we have different type of devices. So you have to be fully aware about all the possibility and the side effects of this surgery. So what's about cervical dystonia? Because generalized isolating dystonia is not so common. It might be much more common to have cervical dystonia. So here we have some papers that have been published, even the paper from Richard Walsh, who is here. Because the population who has been operated is not as big as the other two studies, the German and the French study, we still don't have a huge strong evidence, I would say, which supports this treatment. But you will see from the videos that it's just a question of numbers, a question of publishing more data, because it really works very well even for cervical dystonia. So we will see. You try to. This lady you can recognize. You can see that she has an enterocollis and then a very severe torticollis, again from Toronto. Yes. And of course we have treated her with the botulinum toxin, but for many years, not only me, all my colleagues in Toronto, and she didn't have very good results. Sometimes, you know, you might develop antibodies. So then I show you the pallidum, and then we have another target that you saw in the video, which is called the STN. It's a small target that we use a lot for Parkinson's disease. It turns out that it works also for dystonia. So there are some surgeons, above all in China, in Shanghai, that they use this target for dystonia. But it looks that both targets are really good. So by now, we don't have a strong evidence to say it's better one or the other. We leave the surgeon, right? Because it depends also on the skills of the surgeon. So if the surgeon prefers the pallidum, we do the pallidum. If he prefers the STN, we'll do the STN, because the results, they look very similar. So the problem that we have with the cervical dystonia, because we don't have a huge number of patients who has been operated on by now, we can't understand which are the predictive factor of benefit. So is because we have, torticollis, laterocollis, retrocollis. We don't know, right? By now, we can't understand who are the best candidate for this surgery. And genetics. In Ireland, I don't think you have a lot of genetic forms. Well, in Grenoble, we see patients with mutations. So this is the YT1 is a very common mutation, is an autosomal dominant mutation, which dystonia starts when you are 7, 8 years old, and it affects the legs, and then it spreads. And it can be extremely, extremely disabling. You can imagine these kids, they can't walk, and is very difficult to manage. And so basically they are in the wheelchair when they are 12, 13 years old. And so you can imagine how bad it can be the life of these children. So this treatment make them basically normal. So you can imagine what does it mean for the children and the family. So this is the reason why it has been also so popular in children, because really you change completely the life of these patients. And then there are other form of genetic type of dystonia that we operate with good results, but not as good as the YT1 dystonia, and we don't know why. So in these slides, the most frequent dystonia, actually, they are dystonia that we see after a stroke, dystonia after some neurodegenerative disorder, and other types of dystonia, cerebral palsy. So I put together the number, you can see the number of patients published. They're not huge. This is a form of myoclonic dystonia, 15 cases. This is tardive dystonia, when you take medication for depression or this psychosis, they can induce some dystonia, so it's called a tardive dystonia. This is some neurodegenerative dystonia, and this is cerebral palsy. So these are the percentage of improvement. So you can see that myoclonic dystonia, which is the genetic form, tardive dystonia, they improve quite nicely. A little less neurodegenerative dystonia, and cerebral palsy only around 30%. Why is that? Well, you can see because the damage is highly damaged in these children. They had some perinatal insults or hypoxia, so the damage of the brain is quite consistent. So there is some, in any case, there has been some debate if we need to operate these children, they become adults or not. So I will show you a video about that. So this is an Italian study after 5 years of operating people with the cerebral palsy. And you see, actually, they had a nice improvement, and it looks that is persistent in any case after 5 years of this kind of surgery. Just to give you an idea, what does it mean to have a cerebral palsy? This is a young man who had a severe brain injury when he was born, basically, with this problem, and he never walk in his life because he has spasticity. So he can't use his muscles, he can't use his legs. You have that he has this kind of huge movements in the arms, and you need to be two people to make him standing. And you see the feet, he can't walk in this way. So he has never walked in his life. He has also some cognitive problem. So, and he came to see us, not he, but the family asked us to do the surgery because they wanted him to walk again. Do you think that this expectation is realistic? What do you think? If you have a child who has been like this for 35 years, with a lot of spasticity doesn't mean, it means that there is a huge damage in some pathways that they control the movements. It's like after a stroke, basically. So would you like to consider this person for having surgery, just for treating the movement, the big movements? Well, at the time we decided, because he was so severe, so disabled, the brain MRI was not a major contraindication for having surgery, and there is evidence that these big movements with this surgery, they go away. So we decided to operate this cerebral palsy case, and you will see after a few months. So, of course, this surgery implies that the surgical team works very well together and has the knowledge to perform the surgery and to follow afterwards patients with this surgery. Because they've been published, there can be some side effects related to the stimulation, to the parameters. So the people, the physician, the team have to be, expert. And they have to have experience to be able to overcome to troubleshoot the possible side effects that you can have. So, if I want to wrap up, I would just say that if you have a dystonia in which with a normal brain, we do the MRI, we don't see anything, that we call primary isolated dystonia. It can be generalized, as you remember the first lady that we show. It can be just segmental, as we saw the man with the head, the trunk. The evidence is pushing for considering surgery if medication and botulinum toxin, they don't reduce the disability enough. If you have a cervical dystonia, again, medication, we don't use them very much, but sometimes, physiotherapy or botulinum toxin treatment, and both together, they don't work very well, and you are still working, you can't do the usual thing that everybody should do or can do. And so you have disability, and you feel that this disability is important for you, you might be considered for this kind of treatment, and there is enough evidence, you saw the video, that it will help. At least like botulinum toxin, but most of the time more. If you have other forms of dystonia, in which maybe the brain is injured because you had a stroke, because you have another type of disease, so it's more variable. So you can be improved, but you cannot be improved as well. So we don't have enough evidence, but the message, if the brain is relatively preserved for having this kind of surgery, again, if you have enough disability, I personally would recommend this surgery because you might have some improvement. So it will be a pity not to have it.
Hello, my name is Idal, and I'm here actually on behalf of my mum. She has the cervical dystonia, and it's clearly evident, obviously, from the videos that the benefits in terms of the neck and the reduction in the shake of the head. But I'm just wondering, does it have benefits in reducing the pain associated with it as well?
If the pain is related to dystonia, because the muscle contraction, yes. If the pain is related to cervical arthritis, this is the reason why we do an MRI, right, to see if you have a degeneration of the bones, you have an hernia, right, an herniation of the disc, that it won't improve because this is another anatomic region which is not involved in the surgery. But if it's related to the dystonia, that is the first symptom going away. The pain goes away because it's the muscle contraction. So it will begin. So that is the reason why we didn't show everything. But the pain is one of the symptoms going away quite quickly if it's due to dystonia. So it's quite interesting.
Hi, I'm here on behalf of my daughter who has severe quadriplegic cerebral palsy. Some of the things in the north of Ireland we notice is that a lot of children are being diagnosed with epilepsy rather than dystonia.
Yes.
But on your video where you showed the young fella that had severe dystonia,
Yes.
his feet had turned in. My daughter's feet would be like that, and she has severe dystonia throughout her body where she can't sleep and her bones all contort. And how would you know if it's the dystonia is actually causing her ankles to turn in other than the cerebral palsy? Or is there a way of determining that?
Well, you know, sometimes it may be difficult for the neurologist to assess the severity of dystonia when there is spasticity, right? Because they have any kind of movements that you saw in the video. But usually a good neurologist, with the help of the rehabilitation people, with the help of the pediatrician, we can tell. We can tell which, if it's more spastic or more dystonic. But epilepsy is not a contraindication for having. They will do under general anesthesia, usually the surgery. So, you know, under general anesthesia, the brain is quiet, it doesn't seize. So epilepsy is not a contraindication, and usually neurologists are able to tell the difference between spasticity and other movement disorders. So you should be able to tell the difference and see if she's a candidate eventually, right? Of we do even you know, severe, like you saw in this video. We work with our pediatrician to increase the number of young people can have a benefit from this surgery, because you saw in one of my slides that the earlier you intervene and you can prevent fixed deformation. Because if you twist, if you are a young boy, like the girl that you saw with the feet like this, and they stay years like this, all the tendons, the bones, the joints will be destroyed. So you have to intervene quite quickly to prevent this kind of injuries. So,
one last question.
Okay. Hello, my name is Noreen, and sometimes it makes me feel down a bit because most of the solutions are related to surgery. I'm allergic to anesthetic. I get anaphylaxis. So it isn't an option for me. None of those things are an option for me. I have had to have surgery, and I've had to have it practically in my senses, you know, for falls and things like that I have experienced. And I just that, I was diagnosed 30 years ago, and nobody knew anything about dystonia or even knew what I was talking about.
well,
it was difficult, and it's getting, it has been getting progressively worse as I get older.
Well, by now, all these surgeries, so you can have under local anesthesia one part of the surgery, so the localization of the target, you saw in the big video the electrode was going down, can be done in local anesthesia. But to put the pacemaker, that is painful. So you can't survive because it's very painful, so you should be in general anesthesia by now. There are some new treatments that have been tested. They are being tested for essential tremor and sometimes Parkinson's disease with the lesion using ultrasound that might not imply the general anesthesia, but they are still under investigation, and they've never been tried in dystonia to my knowledge. So maybe in the future, the technology is evolving, but by now, one part of the surgery is in general anesthesia. Or all the surgery, or at least the second part, so unfortunately.